First off, let's go to item 2, overdose statistics. We in Palm Beach County have been bucking the state numbers. The state has been going up year over year. The last couple of years, we have been going down in terms of our opioid overdose deaths. We're in the packet that you received. We have information from the medical examiner from 2021. That's of course finished, done, and it's out on the FDLE statewide report. We had 657 total overdose cases, not just opioids, and then 519 opioid overdoses. That's 79% of the total. These are accidental overdoses. And fentanyl cause or presence in 2021 was 91%, so 9 out of 10. Now in 2022, we're very close to having complete numbers from Palm Beach County. We won't receive the numbers from the state until next November, early December, but we always get our numbers from the county as they finish their toxicology review. We have 5 pending cases, so we're pretty much in the pocket, but this is still a snapshot. We're doing very well this year. Well, we're doing very poorly, but a lot better than in the past. We show, if the numbers continue, with 5 remaining pending cases of suspected overdose, we have a 19% drop from 2021, from 519. The predicted number in 2022 is 418. 76% of total overdose cases in the county. 93% have the presence or cause as fentanyl. I'm sorry, 422 would be the predicted number. 418 is what we have counted so far. But that would equal a 19% decrease year over year from last year. So we hope that trend continues in the last few cases. We'll have all the cases, the final numbers, pretty much done in the June meeting in 2 months. Of course, we've talked about Tranq, xylazine. In your package, you have 2 articles about it. It's a scary animal tranquilizer. It's equivalent to fentanyl, and it's being sold with fentanyl. So there have been in 2022 so far 36 OD deaths that the cause of this is Tranq xylazine. That is not an opioid. Okay, it's a tranquilizer, an animal tranquilizer, not an opioid. Also, we have increases in some of the new fentanyl analogs. NPE, if you see on the bottom of this page, we have 0 in 2021. We have 20 so far that NPE is the cause of death. Fluorofentanyl, similar. It's gaining in popularity, as an analog. It's similar potency to fentanyl. NPE is 20 times more potent than fentanyl. The fluorofentanyl, we had 6 last year, we had 100. That's captured in the total number of the fentanyl presence and death. The next page involves the transports for suspected overdoses. This is just a snapshot of the first 3 months. So everything you see here is the first 3 months of each of the years from 2017 to 2023. So you have 7 years of data. And this is just the Palm Beach County Fire Rescue, which roughly approaches 50% of the county, because we have individual municipal fire departments in a number of municipalities like West Palm, Boca, Riviera Beach, Palm Beach, etc. So the numbers have been going down. Other than last year, it was in the first 3 months, they seemed to go up, but I can tell you that the year over year in 2022 was down from 2021. But the actual number I just want to mention is the net change over the course of the last 7 years is a 53%. And again, this is the first quarter, 53% reduction in transports. So I think that's pretty good news. Let's move on to Delray Beach. Ariana, do you have anything you'd like to share with us? Ariana Ciancio.
Sure. I know that I reported in, I guess, February's numbers were really.
We're losing you.
She muted herself.
You seem to be muted, Ariana. Yeah, I think she got dropped off the call. Okay, let's move on. We'll get back to Ariana. And I want to have, if you will, Heidi Matheny. Am I pronouncing your name right? Is it Matheny?
It's Matheny.
I'm sorry.
Okay.
Heidi Matheny with FAR. She's going to give us our current statewide data and the trends. Can you get this up on the screen? Or are you going to do that, Heidi?
I have the report up. But so statewide, on the report that I submitted to you, Al, I didn't put the statewide numbers. Currently, we have 7,717 beds in the state. And we counted, as of yesterday, 205 providers. For Palm Beach County numbers, we've got 92 programs. So out of 205 providers, 92 of those providers are in Palm Beach County. And our bed count in Palm Beach County is 3,280 beds for Palm Beach County numbers. We're noticing an increase. We've had a substantial, increase every year, a steady increase, a rise in numbers. We are noticing an increase in inquiries, calls in the northern area of the state for certification, like Jacksonville and Panama City area. We're getting a lot of calls up in that area. Out of our bed count, levels 2 and 3s, we have 1,791 beds in Palm Beach County. 585 beds are MAT. We still, have a huge deficit in MAT beds in Palm Beach County in the state overall. And level 4 treatment centers, we have 1,498 beds. 710 of those beds are MAT, so it's almost 50%. And so, like I said, over the state trends overall, we've had a steady rise. That's only increasing. As I mentioned, for 2023, we have 7,717 beds. And I will have much more information next year. I mean, next meeting. I'm sorry. I wish I had more to offer at this point in time. We have approximately 35% of our beds, I believe I mentioned that, are MAT. We definitely need to, we're pushing for an increase on that.
Okay. Heidi, anecdotally, because I know you don't have this on your data sheet, but where have you seen the most increases in FAR certification around the state?
The most increase currently is in the northern part of the state, I think.
Panhandle, Jacksonville, around there?
Yes, sir. Mm-hmm.
Okay. Thank you. Any questions for Heidi? Okay.
I have a question, Al, real quick.
Sure, Courtney.
This is an anecdotal question. I was wondering, I know that there's a lot of MAT beds, and over the years I've been in Palm Beach County, it's gotten better in the sense that they're more open-minded for sure. Do you know if there's something that FAR assesses in terms of dose limits on certain MAT medications?
We don't assess dose limits.
Okay, so it's up to the individual house?
To the individual house, the individual provider, yes, ma'am.
Thank you.
Mm-hmm.
Dr. Phillips, can I just say this on behalf of FAR. I mean, one of the things that I've reached out to the Florida Society of Addiction Medicine is to come and do some presentations for FAR providers specifically on MAT, the current state of MAT and all that kind of stuff. So can I reach out to you
Yeah,
afterwards?
yes,
Okay.
yeah, I'm still
You're
actually.
on, Courtney. I'm after you. Thank you. for stopping by.
Because I'd love to work better with housing. I'm at Wayside House and I still am the director of behavioral health contracted at the healthcare district. So I'd love to work as a collaboration with housing projects. That's fantastic.
You got it.
Thanks.
Well, one of, it's very important that we expand the number of MAT beds, and I think that we might this might be part of the discussion later on in the MAT 4.0 agenda item. One of the things that's holding back dollars, federal dollars and state dollars, is these grants are heavy MAT grants, and when you don't have MAT, you don't get the dollars. Now, and one of the things I think, Susan, you were the one who brought this up. We need to think of this no longer as on MAT. A patient is not on MAT. A resident is not on MAT. A resident should be in MAT. It's a program. And I think some of the same biases that the general public may hold for people with substance use disorder are in microcosm become biases of people within recovery against other people within recovery. And that's counterproductive. I'm kind of on the soapbox now, but we need to educate, because we no longer can afford to shoot ourselves in the foot and lose out on money that could go toward recovery because we have these biases against certain areas of recovery. And I'll leave it at that, but thank you very much, Heidi. John, you are going to give us an update on the county contract with FAR.
I am, Al, thank you, and I appreciate the time. And if I could, Al, ask if I could just package item, what I think it's F or G, or package my two agenda items together, because I'm going to have to jump relatively shortly. I'm at a community event. So
Okay.
If you don't mind, just to package those two together, thanks. So thank you, and certainly have appreciated our now contractual relationship with FAR, the team, Michael Cabot, Heidi, certainly a lot of work with Susan as well. To enter into this this relationship has really been important. So to talk specifically about the contract, Al, our agreement, we're deeming it the Recovery Capital Initiative, and what we're seeking to do, Al, is to educate, train, and engage the certified recovery residents here in Palm Beach County regarding Recovery Capital Index, which is our initial launch into our outcomes is largely hinging on assessing Recovery Capital Index with it, in the individual, developing individualized recovery plans, and hoping as we see greater resilience built in an individual, building that capacity not to have to lapse back into care, particularly deeper end care. So we have that interest in appropriately measuring long-term recovery outcomes in the recovery residence environment through the use of the RCI. And really the aim of the project is to build recovery capital capacity within the FAR certified recovery residents in Palm Beach County. And the intent is to continue to foster an environment, not only within that, but countywide, that maximizes a resident's opportunity to achieve long-term recovery outcomes through education, monitoring, and the measuring of outcomes. Recovery capital is not a new concept to FAR. If you look at the criteria and the requirements to be certified in FAR, there are data collection requirements made of sober home operators.
Yes.
And additionally, there are requirements around developing recovery plans for housing residents. So I think there's a really good marriage between what are some requirements criteria wise, and then ultimately providing an instrument, the Recovery Capital Index, to all recovery residents, operators and homes in Palm Beach County, to utilize that tool to achieve not only their aims and meeting that criteria, but ultimately the aims that I've just suggested. And as Heidi just suggested, we of all counties should have a great interest in what's happening in the recovery residence environment. In essence, both programmatically and from bed capacity, we're, somewhere hovering between, 40 to 50% of all capacity statewide. And, housing stability, when we look at trying to achieve long-term recovery outcome, housing stability is a key predictor in achieving that outcome. So, that's the initial push out of the contract. And additionally, Al, you certainly in your office and us as a task force and in the county, we have a keen interest in, ensuring that these recovery residents are certified, number one, and are regularly screened and monitored to provide a safe and stable housing environment. So another aim of the initiative, Al, is to make sure that FAR has sufficient capacity to achieve this aim, and there is a requirement for them that they report to us monthly on grievances that have been filed related to sober recovery residents in the county. So we get to track that, particularly as the county considers how do we begin to expend or appropriate monies in that recovery residence environment. Along the lines out of the MAT discussion, another aim of the project is to increase MAT bed capacity and increase the availability of certified housing programs in the county that are willing to receive government-funded housing support and participate in government-funded recovery housing networks. Our federally funded COSAP project has given the county the opportunity to really do our first deep dive and interaction with recovery residents, and that part of the equation, although it seems rather straightforward and simple, has been very, very difficult, not only from an MAT perspective, which is nothing new to us, but also from trying to engage operators, in a government funded system, obviously where there's more accountability. So, there's some educational aims and objectives within the contract. FAR and Heidi and her team have been working closely with our vendor, the Recovery Capital Index vendor, doing trainings, and so we're working at it very diligently to get the FAR residents, certified residents, into our overall body of work, and the board's aim of establishing a person-centered recovery-oriented system of care. That's the ultimate aim is to improve long-term recovery outcomes for our population. So I'll do the other report, and then if there are any questions, I'd absolutely be glad to field those. The board, and I'm glad that Mayor Weiss is on the call, and their wisdom. There are a couple of things that happened in November of last year. That two things. First, the board via ordinance established a advisory committee on behavioral health, substance use, and co-occurring disorders. The requirements of that were to not only have that advisory body, but also a major requirement of that ordinance is to, on an annual basis, is to issue a master plan, if you might, on behavioral health and substance use disorder here in Palm Beach County. With respect to that, Al, I know you've been involved in that process, as have many others on this call. The preface to that was a steering committee that was operationalized by the Community Services Department in 2019. And we'll recall the history here in Palm Beach County. The first guiding document in response to the opioid response plan, or opioid epidemic, was the response plan the board adopted in April of 2017. Two high priority recommendations of that plan were first to hire or appoint a drug czar. I think it was actually to lead the opioid response effort. And that, of course, is me. And believe it or not, Al, in 11 days, I will have been here officially 5 years in Palm Beach County. So time certainly goes fast. But the second major recommendation of that was to establish what they reference as a steering committee to guide the effort. So, the steering committee was the preface to the more formal now ordinance enacted advisory committee. So Al, if I could, I don't know if I can upload documents into the chat. There are a couple things or a few things I'm going to be uploading. One is the master plan that was ratified from the steering committee's work of last year, ratified by the board in November of 2022. And the emphasis there has been, very consistent of the work that we've been doing, almost since my arrival. And that is really much more recovery orientation and a longer term view beyond just acute treatment. So, again, that major aid of the board is to establish a person-centered recovery-oriented system of care. I also, Al, I'm going to upload the steering or the advisory committee schedule for the rest of the year. And all things are operating via Zoom. The advisory committee is meeting in person at Mandela on East Avenue in West Palm Beach. And then the the subcommittees, of which there are 7 strategic areas that really follow the initial opioid response, is meeting bi-monthly, all via Zoom. And that's really where the rubber is hitting the road. That is where we are bi-monthly receiving community feedback. And that feedback is directly inputted into what will be another master plan update due October 1st to the board. So we're working diligently. All those subcommittees are facilitated by a new team member of mine, our program evaluator, Dr. Ellen Jones. So we're trying to make those meetings really meaningful, and I just hope for the communities views it as a way of definitely weighing in on these issues. We welcome broad and wide participation, including members of the task force here. I think that's about it, Al. So I'm certainly open to questions.
Yeah, and John, why don't you just send those documents to Mary Ann, and she'll send it out to the entire task force, as well as all the that have that receive our attachments.
Excellent. I will do that, Al. Thank you.
All right, any questions for John? Thank you, John. Now we're going to do Oxford House, Lori Holzclaw Hunt, and then Ariana. I see you're back on, so we'll end the updates with you. So Lori, how's Oxford House doing?
They're doing pretty good. I'm going to share my screen. All right, for as of last month, the total houses is 125. We have 1,129 beds, 78 men's houses with 710 men's beds, 1 men and children's house with 8 beds, 25 women's houses, 217 beds, and 21 women and children's houses with 194 beds. These are the current cities that we have Oxford houses in throughout the state, and that continues on to this next page. Our future, where we're looking to expand, these several cities right here. We've had one non-fatal overdose revived with Narcan in the Broward area, Fort Lauderdale, since the last meeting. Our upcoming events is our state convention, May 5th through 7th in 2023 in Orlando. We have the World Convention, the 2023 World Convention is going to be at the Gaylord National Harbor in Maryland. And then the 2024 convention will be at the Rosen Shingle Creek in Orlando. Oxford houses in Florida are thriving with many positive developments and events taking place throughout the state. All areas are currently gearing up for the Oxford House Florida State Convention, which will be held in May. This convention serves as an opportunity for members of the various Oxford houses across Florida to come together, share ideas, experiences, and strengthen the overall sense of community support that is integral to the Oxford House model. In addition to the upcoming convention, many individual houses and chapters throughout Florida are actively working to maintain a sense of unity and camaraderie amongst their members. Regular unity events are being held, which provide opportunities for members to come together, share meals, and participate in group activities. These events serve as an important reminder that recovery is a group effort, that fellowship and community are essential components of the recovery process. Furthermore, training sessions are being conducted throughout the state, which aim to maintain the high standards of service and support that are characteristic of the Oxford House model. All chapters in the state continue to do Narcan administration trainings, and some areas are designated to be Narcan providers in the iSave Florida database. These are our websites, and then these are the contacts. Myself, the Director of National Field Services, and then Michael McKeough, who is the Regional Manager for Florida.
Okay,
And that's it.
Jeff Lynn, you have your hand up. What, have a question?
I do. Thank you, Al. Can you hear me okay?
Yes.
Okay. Lori, thank you for that. Al, I have a question generally, and this may not be the forum or place for it. If not, we'll another time. I know this isn't a hearing. I just have a question. Now that Oxford House appears to be in the state and appears to be doing successfully, because they're not all, one, I don't know how many Oxford homes have registered or have voluntarily chosen to be FAR certified. So that's an interesting data point I'd like to know, just out of curiosity. It doesn't need to be today, but I'm just curious how Oxford House is integrating with how Florida does it. And second, there's just been generalized commentary that I like to dispel. I don't know if it's true or not, that, you know, Oxford houses are not working out necessarily as we hoped they would, with neighborhood compatibility, oversight management. That might just be a rumor that's unfounded, and gosh knows this industry is filled with those kind of things. But I would like to know, you know, that we were always supportive and will continue to be supportive of Oxford House, but from a regulatory standpoint, where I'm looking at it, I want to know, or would like to know, or talk about at some point now or in the future, how is it actually working out in Florida, besides just successful number rates? So that's my question generally is, you know, how's it actually working out for us? I don't want to continue to espouse the greatness of Oxford House without actually knowing how it's working out, and to identify whether there's some things that we need to tweak under how things work here in Florida. And this is a venue for that. So that's kind of my question.
So Oxford houses charter their own houses, so we will never be FAR certified. We are our own credentialing body. And as far as how is it working out, I'm not really sure exactly what you're talking about. I mean, the outreach workers are always here and available for you to come visit anytime you want to any of the Oxford houses. You are welcome to come to any of our events to see how things are going. What exactly is it that you want to know?
Lori, let me,
There's regular complaints that get filed to FAR on a regular basis, grievances that are determined and are founded or unfounded. I didn't know if there was a similar process with Oxford houses or not.
So I've only received 2 complaints from FAR through so the complaints that I've received, Whitney emailed me or Steve has emailed me in the past.
Let me interject. Let me translate to a couple of things for Jeff. I think, and Jeff, you can tell me if I'm wrong. Do you have an internal complaint system where you can assess the validity of complaints, whether they involve the safety and health of the residents? FAR has a mechanism to investigate complaints. Do you have a system in Oxford House? And number 2, and if Jeff didn't mean this, I'm going to ask you this. How's it working out with regard to locating in communities? Are you having cooperation from local government? So those are the 2 questions.
So I feel like if anybody has a grievance, they can do similar to FAR, is go onto the website. We have the national phone number on there that people can call, which goes to our main office, which then in turn gets sent to us locally. And then we also have the info at oxfordhouse.org that people can send it to. And we have the state website that people can send the info if they want to talk to someone in Oxford House on a state level. They can email the state.
Yeah, you want to live that lifestyle.
So then what happens then is it gets directed to the outreach workers. The outreach workers then contact the person or the local house to see what's going on, and they investigate it from there. So, I mean, yeah, in essence, we do have a system in place, and we deal with those all the time on a regular basis. As for the communities, what are you talking about? Like, are we received well in communities? Or
when you're dealing with local governments, let me ask you this. I was going to ask, when was the first Oxford House opened up under the new contract with the state? When did you open up the first Oxford House? 4 years ago? Would that be about right?
Yeah, it was, I believe it was March, either February or March of 2019.
Okay. Well, every time you open up a house, you charter a house, there has to be some process that you go through in terms of local government because of zoning rules and regulations. So I guess since you're spread out all over the state, how are you doing? Are there trouble spots? Are you finding that the local government itself, not the residents, but the local government itself is cooperating or following the federal law and also to an extent state law?
It depends on the area. So most of the time we will file for a reasonable accommodation, and normally it kind of stops there. They provide the reasonable accommodation and then we just move on. We obviously have had issues with Panama City. It seems to be an ongoing, they're not as receptive there. And then I think we have one other situation. I think it's Orange Park that we're having an issue with. But other than that, for the most part, it's going fairly well. I mean, we open the Oxford houses and they do fine. Sometimes they don't like us there, but either they provide most of the time they provide the reasonable accommodation. And then after a few months, they see that, everybody's, doing what they're supposed to be doing and they're okay. So.
Good. All right. Thank you, Lori. Any other questions before we move on? Ariana, are you back with us?
No, she got kicked off.
Oh, she got kicked off again. She said the numbers, she actually did say the numbers are better this month than last month, and we'll just leave it at that in terms of overdoses in Delray Beach and what's going on in that city. So let's move on to item number 3. Dr. Phillips, you're pinch hitting for Dr. Andre.
Yeah.
we have the addiction stabilization unit. We haven't had an update in about 4 or 5 months from you. So how's it going? And then we're going to talk about, Houston Park is going to get on and talk about the statewide model that's being opened up across the state based on the ASU. So Dr. Phillips?
Yeah. Yeah, it's nice to see all you guys, and I'll just update you on my status because I know I haven't seen a lot of you in a while. I'm doing the statewide opioid recovery initiative with Houston. We talk multiple times a week on that project. And then I'm very excited and I have a few data things to show from that if you guys are interested. We're developing a dashboard for that core project as well. And I work at Wayside House 3 days a week, and I'm still contracted with the Healthcare District of Palm Beach County as an oversight for the program and policies and procedures. So I'm happy to be here. Dr. Andrick is enjoying a vacation right now. It's well-deserved. Do you want me to share it, or do you and Marianne have it? I don't care.
I have just the PowerPoint, Dr. Phillips.
Yeah.
Okay, I can hold on. Let me share my screen and see if I can do it.
I think we have sent out your PowerPoint to all the to all.
Oh, yeah, that was Dr. Andrick. So let me go and make sure if I can stop my video, just stop confusing this. Give me a second. Can you all see this?
No.
We only see
PowerPoint?
your page screen broadcast, but not an actual slide.
Okay, so let me see if I can try one more thing. And if it doesn't work, Marianne, maybe you guys can share it for me. To share. Okay, oops. Share contents. Let's try iCloud Drive. Hold on. Can you share it for me, Marianne? I think I'm having some issues. It's not going to work from my site. You guys have it? So while she's doing that, I'm here representing the healthcare district. So the ASU, there's some big news coming. Yep, there we go. Thank you so much. You can scroll down. The Florida Blue Foundation, the program with Healthcare District applied for a Sapphire Award to address mental well-being through Florida Blue and won a $100,000 award for the Palm Beach County program. That's basically a grant that's open-ended to be utilized in the program. They just won last week, which was a huge honor. It was in Orlando, and something I think I'm very proud of. I know Dr. Andrick's very proud of, Darcy and the whole team involved with the healthcare district and a lot of the community partners involved with this, and is, getting attention of some insurance companies in this way to start to pay attention to programs like this as a possible way or ways to reimburse. So this was a big deal. So we can go to the next slide. And we'll go to the movie after at the very end, I think, Marianne, that makes sense. This is the dashboard you guys are familiar seeing. We see in February, March, certain numbers. I think just because it was mid-April, it hasn't been updated. So you see a low number of intakes in the upper left-hand corner. Other notables that are different, we certainly had, if you look at the bottom, there's a couple things. So length of stay at JFK is actually getting more geared towards 1 day. Why is that? So there's new literature out that high dose inductions right after someone overdoses are really the appropriate thing to do with fentanyl, which is fantastic. And I think Houston will speak about this. That approach to fentanyl is making it so that if someone just used fentanyl 2 hours ago, we don't have to wait very long. We can start them on a high dose 16 milligrams and they usually resolve quickly. So it makes for a beautiful protocol that is being worked on the state level, on the local level for EMS. And it was piloted in New Jersey to basically can do this possibly in EMS space, but also in the emergency room. So it creates a faster improvement in their care, as well as a faster discharge, which always helps with the ER partners because it's hard for them to hold people in the emergency room for long periods. The other notable I'll point out is that down at the bottom, you see the AMA rates went up and spiked in March and April. We did pay attention to that. We audited 20, it's at the red line at hospital disposition against medical advice. For all of you guys who don't know what AMA stands for, it's what we strive to work against. When we saw that spike, we audited all 25 of those charts and sort of did a deep dive. And most of the patients were alcohol users as were homeless. And we're doing some internal data that's not ready for prime time yet to say what, you know, we do have some patients falling out between 4 and 6 visits. In the initial, you know, when we first start doing data, it's hand done. So in our initial chart audits, what we're seeing is that when you have someone with opiate use disorder, we keep them 4 to 6 visits about 70% of the time. But when you have somebody who has a comorbid alcohol disorder and homelessness, we lose almost 100% of them by 4 to 6 visits. So this is a next level data thing that we're starting to explore to say, what can we do better with that group of patients? It was very eye-opening for us. And it just goes to show how important the housing piece is probably to some of this care. And this is at the same time that you're seeing homelessness rise because of the inflation and the housing crunch going on. So we can go to the next slide. As you can see, nothing really here that's new or notable that you guys haven't seen in the past, and you can review it and I'll let you ask questions. We can keep going. And like, this is pretty typical. We're monitoring patient monthly volume. Keep going. And the daily volume as well. There's a constant training that needs to happen in the emergency room level as well. As new staff comes in, sometimes they are not as sensitive all of a sudden to a substance use patient, and it needs to be retrained. And that's been a challenge in Palm Beach County as well as in the state. Whenever there's new team members on either side, you have to really retrain them to kind of keep doing motivational interviewing with the patient, meeting them where they're at. Go ahead, next one. In terms of the clinic, you continue to see a mortality benefit, and I'm glad to see that at the medical examiner's office, after so many years, it's starting to make a dent. All the initiatives going on in Palm Beach County, the global initiatives with all the different partners is making a dent in the overall, but we see it also in our little clinic population. Homelessness percentage continues to increase. Like, just to give you perspective, if you look at the top, you saw last year and 2 years ago would have reported more in the low 50s. It's now, it was last, I think 6 months ago, around 62%. So now it's 64%. So like I said, these Oxford Houses FAR collaborations are so important. And going along with what I'm seeing when we do these hand done reports about homelessness, really making it harder to keep them engaged in care. It is an important initiative. Next slide. This is the long-term brief addiction monitor that's now up to 5,380 surveys. This is over time that someone's in the program, but I wanted to present this a little differently to you guys because I like to be transparent. So when we looked at the number of people who are entering at the 0 and 3 months interval, meaning that's when they entered the program, the numbers are very large. And when you look at the number of people entering a 60-month, which is almost 5 years out of the program, it's very small. How does that happen? So let's pretend Al Johnson is our patient. Al comes in for his first episode of care. He's there at 0 months, 3 months, 6 months. Then he gets, let's say, incarcerated. We don't know what happened to him. He leaves for 7 months. He comes back and says, oh, I liked you guys. I just got incarcerated. He gets measured again at 0, 3, and 6 months. So one of the things we did was look at the next, if you look at the next version of this, you can go to the next slide, Marianne. What you see is we said, well, forget, oh, I think we lost it. Go back to that top one, that last slide. Okay, so this is a little different iteration. Rather than looking at months, looking at the total number of BAMs completed by the patient. So if Al's been with us with 3 different episodes, incarcerated one time he relapsed, but he got measured at 0 and 3 months. This time we said, forget how many months he was. Let's just look at the number of BAMs he did. What we saw is that the sample size really starts to spread out. So we get a lot more at number of BAMs completed, 4, 6, 7, 8, 9, 10. And the more BAMs somebody does, the better they do, which continues to give, you know, my interpretation of that as a physician is the more we see that patient engage in some sort of care, the more likely they are to develop these functional improvements in their recovery. So that's the healthcare district data. And before we show the video, I wanted to ask if anybody had a question about the healthcare district data, and then I can give you a little bit of information on core before Houston goes into more details with the EMS side of it. Okay. I have some beautiful dashboards from core that I prepared for today. I didn't get them in time for sending them to Marianne, and I'm obviously having some difficulty screen sharing, but Al, I'm happy to send them to you guys to look at if you want to send them out to the partners. But long story short, I just wanted to mention how proud Palm Beach should be for being the example for this program. It's really taking off. Many counties were so impressed by the dashboards and the task force, what's going on here. This is the only county having a reduction in death rates, but hopefully the others will follow suit. So just to give you guys a taste, what we did is we broke down 22 components that make a successful Palm Beach County model, evidence-based components. We assessed each county for these components back in October by meeting with each set of groups. They identified with contracts who could be a receiving clinic, like the healthcare district, who could be emergency room, and EMS partners. And across those, we gauged, we said out of the 22 components, there are 4 critical components. Those critical components include fentanyl testing, providing buprenorphine in an emergency room setting to opiate users, completing the BAM. So the BAM is actually a requirement of core programs and will likely be continued on when DCF takes over to create more data for in a mass level, as well as having that receiving clinic. So those are the 4 critical components. Almost all the counties have 100% of the critical components, which was a goal. Some are missing some due to partners issues. And almost everyone has improved in having their components for the program. We educated them on those. Next step was to follow up and start deciding what are the data metrics we're going to follow. We just started inputting into a dashboard called ClearPoint. All the counties have licenses for this to have it be data driven, just like Palm Beach County. They've seen those dashboards, they want them, and they want to see the improvement that Palm Beach County has had. So that's what I had on my screen, and I'm going to be unable to share it, but I'm happy to forward that to you, Al, so that you guys can start looking. Please keep in mind that this is much more rudimentary. Some of these places like Escambia had nothing set up until December. They were just getting all their contracts and organizations together. So it's way more premature and rudimentary compared to what ASU, Healthcare District, and a lot of the partners in Palm Beach County have been able to do, but it's a starting point. And my last comment on that is that the brief addiction monitor is being adopted statewide. I think it's going to carry as the project transitions from DOH to DCF with the opiate settlement dollars coming down. They are probably going to continue that as an assessment tool. So it will all kind of filter in. So with that, I just want to see if anybody has any questions before Dr. Andrick wanted to show the Sapphire video. Okay. Thank you all. And it's really nice to see everybody here. And Marianne,
Okay.
you can.
All
Yep.
right, we had a little technical, we're hunting the video down. And while Marianne gets the video to play, many of you remember when, back in the day when we used to have 2 task forces, the upper house and the lower house, we'd meet twice a month. And then we went down to 1 civilian task force meeting once a month. And during that process years ago, I mean, Houston Park just took the bull by the horns, and between he and Darcy Davis, Belma, Andre, and Dr. Phillips, and the board of JFK, they were able to cobble together separate silos. And no, go ahead and play the video. If you get that video up, I'll finish when it's done. Okay, there we go.
You see an individual.
I don't see it on the screen now.
We know when we're starting this journey, we feel alone. We feel like we're lifeless. And so when your life begins, it starts at the beginning.
Yeah, and just while Al's bringing it up, I just want to say, like, you guys have been an example for the state. This is at 12 counties, but it's expanding to 17 more through DCF. So congratulations. not only have you guys changed Palm Beach County, you've
That's
changed
played twice.
the state. So thank you.
We had this information in our thoughts. 2017, and we began this pilot program. Because what we really needed, what was missing, was someone who's going to treat these patients.
There it is.
Lifelong. It's like a primary care practice, treat you, you have high blood pressure, lifelong. Like a lot of people, I became addicted to opioids because of prescription medication. And the addict gene was there. It just took that opioid to be prescribed to me. We're very proud of Matthew. Matthew started with us at around maybe 2021. And since that time, he has really tackled his addiction. Had never used needles before, was injecting fentanyl, was using methamphetamine, drinking a couple bottles of vodka a day. This program absolutely functioned 100% on warm handoff from this addiction stabilization unit, who is just next door to us. That warm handoff connect them to the outpatient clinic where they learn a lot about chemistry of their brain. And this place has saved my life. It's 100% saved my life. I know that for a fact because coming in here, they've given me all the support. They have given me the medication. And now I come here knowing that I can help save other people's lives, which is very gratifying in itself. If I need to summarize this program in one word, the one sentence, it would be that we are really trying to medicalize this illness because those patients can get better and do get better.
So it's not one particular medication that's going to help a patient towards recovery. It's part of the solution. So it's medication, it's therapy, it's a sense of community that they get when they participate in our group sessions.
Just the all-encompassing program. And there's nothing like it that I've ever seen. It's just been such a tremendous help for me.
I can tell you early on, I observed a patient who came half naked after prostituting herself on the street, but the patient didn't have shoes. And before the patient went to the cop, one of our employees took off her shoes and gave to the patient. A few years later, we actually heard back from that patient who is now in sustained recovery in her home state. And she actually established a non-profit organization that gives shoes to the homeless patients suffering from substance use disorder. This illness is impossible to treat, even if you deploy all evidence-based medicine tools, if you don't give this compassion.
Congratulations, by the way, on winning that Sapphire Award. And what I was trying to say was, it's so difficult sometimes to get disparate silos together. And in this case, and Houston, you can probably fill in the blanks, but this started as a pilot program. There were halts, there were stops. The county stepped up to the plate and put in millions of dollars. Sure enough, we actually got a trauma model out of the JFK North. It's basically phenomenal what happened. So anyway, with that, I'll hand it over to Houston. Go ahead and give us the skinny on what's going on in the state. If you're still with us, Houston Park. Houston, we have a problem. There you are, I see you. No, we can't hear you. No, I can't hear you. Is the volume on your phone on? No. I'll tell you what, let's move on. And then when you keep trying to get some sound, and Mary Ann, why don't you let us know when we can hear Houston?
He's not muted, look.
Oh, you are muted.
No, he's not.
Okay, I see a mute.
Al, I really appreciate all of you. I just wanted to see if there's anything else because I do actually have some patients on my schedule.
Well, go forth and prosper. Thank you.
Yes, thank you guys so much. Great to see everybody. Have a good one.
You appear to be muted still, Houston. I'm showing that you are muted. All right. Okay, okay, he'll be coming back, I'm sure. And so let's move on to item 5. Michael Cabot is going to talk to us about FAR 3.0. What's going on with FAR, and talk about some of the ideas that are flowing.
Well, thank you, Al. Nice to meet everybody. I know some of the people on the task force, so good to see you guys again. It's been an exciting 18 months at FAR. We have been actively restructuring the board. We have rewritten our bylaws. We have been reworking FAR's policies and procedures and working on our operational efficiencies. Some of the highlights to date are that we have a 10-person board, which is behaving more like a working board versus a society board. The executive board, which is made up of the president, vice president, treasurer, secretary, along with 2 other board members, currently are meeting twice a week with FAR staff to collaboratively work together on the operations of the organization, create goals, and implement strategy. One of those strategies that we identified as an issue was that it was taking too long to get certified providers through the process. And we realized that in particular, level 2s, there was a backlog of level 2 due to the fact that it was difficult to interpret NAR standards. So what we ended up doing is we ended up creating a template that basically is a minimum standard for level 2s that they can use as a baseline to work off of that document to create their own policies and procedures. And that has helped us kind of move the log jam through the certification process. When I first came on the board, the certification process took 6 months. Our aspirational goals are to get the certification process down to 30 days. We're right now at about 60 days and getting level 2s through the system. One of the holdups, and I think this will be interesting for the group here, is that we needed to figure out what MAT policy looked like. And we analyzed our providers, and we realized that a lot of the providers, especially at the level 2 level, were not comfortable with MAT protocols. So it's our opinion, after discussing with NAR, who also doesn't have necessarily a MAT policy and procedure, they basically just have a medication storage policy and procedure. Our opinion at FAR is that if you discriminate solely on the base that someone is in a federally approved MAT protocol, that you are in violation of the ADA and fair housing. So that's our baseline. Now, what we need to do is we need to do a sales process to get our providers in lockstep with that positioning. So with our first round of documentation for our minimum standards, we just identified a medication storage policy and procedure, and we didn't necessarily talk about MAT because it's assumed that if you are discriminating solely on the basis of MAT, then you're in violation of federal law. With that said, there is a out, which is an undue burden. And it's our opinion at FAR that the undue burden is really not to be put on FAR to make that assessment. It's really on the providers to make that assessment. Now, with that said, I'm breaking news here, Al, talking about FAR's position on MAT. We have to then sell this process to our certified providers. And we are going to have a committee that will discuss that. One of the other exciting things that we've been working on is we've been working on a level 3 template and a level 4 template. And we feel that these templates, which will create a baseline statewide for people who want to become FAR certified providers, will allow them to kind of understand what the minimum standard. They can always do more, but they can't do less. So we're very excited about implementing the minimum standard and the templates that we have. We've also started reworking our appellate process. So what we analyzed after looking at the way FAR operated, there was 2 silos. There was a certification silo, and then there was the compliance committee silo, and they didn't really talk to each other. So what we have done is we've actually implemented a strategy where now we're putting a board member on the compliance committee. The compliance committee has joined, members of the compliance committee have joined procedures committee, which is in the process of rewriting FAR's appellate process. And we have reached out to stakeholders in the community to join that committee. Jeff Lynn, who is a member of this task force, has joined that committee and has started to help us to rewrite the appellate process that's more in tune with other agencies and how they view an appellate process. Now, with that said, we will be having other committees in the future, and we welcome stakeholders in the community to join and be part of those committees. We will be talking about MAT. We will be talking about, there's a hot topic of zoning statewide. We'll be talking about that. I'm sure we'll be working with you, Al, in implementing Mr. Lauber's, minimum zoning thresholds for other cities to adopt. So we are actively want to work with the community, want to work with members of the task force, want to work with other stakeholders to basically bring in other minds to the FAR process to help us, achieve a more efficient organization that expands safe housing statewide. If anyone wants to be on one of these committees, feel free to reach out to Heidi at FAR. Her email is heidi@faronline.org. Finally, we are working closely with Palm Beach County and the RCI initiative to establish data collection with the certified providers in the county, because we realize that data is really driving funding. And without good quality data, we won't be able to articulate the need and the case for long-term transitional housing as a staple to the continuum of care from people suffering from the disease of addiction. With that said, I'm very excited about the changes at FAR. We have started to expand our reach into other parts of the state through new staffing hires. We feel that we're seeing significant interest in the Northeast part of the state, where we have a person that we're interviewing who works for an RCO. And then we're also expanding our footprint in the West Coast of Florida. So I feel very positive about the changes that have been made. If anyone has any questions, I'm ready to take them now.
Any questions? This is very exciting. The progression of FAR is astonishing, especially since we have the counterintuitive funding of FAR based on the actual providers paying their fees. And as most people that are on this Zoom meeting know and understand, that recovery residences as a business are not extremely profitable, especially if they're legal and they don't violate the law. We'll be trying to figure out ways that we can assist and we've been doing that, but with the new 3.0, I think it'll be easier to get support. So there's an alternate funding rather than just from fees from the providers themselves. But you're doing a remarkable job, all of you, Heidi, Susan, everybody on the board, and Josh, all the folks that work at FAR are doing a phenomenal job. And I do want to, I actually want to give a shout out. I do not agree with the method and the manner, but I will say that Tori Perfetti, one of the treatment providers and FAR certified at CRRA as well, nice guy. A lot of what he suggested, not in the bill that he filed, but in the meaning behind the bill. A lot of what he suggested is really good stuff. And I like that FAR has adopted a lot of those goals. And I think the complaints that you've been receiving will fade away with this new 3.0. Any other questions? We'll move on to, I hope, Houston, are you with us? You're still not, still can't hear you. We're going to have to go back to live. We have to go back to the West Palm community room, although probably a third of you won't be able to show up because you're in Tallahassee or another county. But let's keep trying, Houston, and let's move on to talk about some of the legislative enactments and where we are right now. Did Representative Caruso ever get on? No, okay. I'm happy to say that the fentanyl test strip bill that exempts testing for personal use as to whether fentanyl is present in a drug, which will save countless lives. It is in.
Can you hear me now?
I can hear you now.
Oh, that's good. That's a good thing.
I'm going to interrupt. This is the second time today. Okay, is it April 1st or what? Houston, you're on. Let's talk about what's going on around the state with DOH. Okay.
I know I sent a PowerPoint, but I don't really need to use that. I would like to say that I'm really excited to be still in the fight here with you guys. And as you mentioned, we really started this back in 2015. So we've come a long way. And the efforts of this entire group has pretty much been the standard to set a national model. So I'm working very closely with Dr. Phillips and Dr. Shepke for the Department of Health at the state level. And we've had successfully implemented 12 counties, and we will also count Palm Beach and Broward. So that actually gives us 14 counties where they've implemented a program to provide MAT assistance or therapy. And with that, as you see what has happened here in Palm Beach County with the Addiction Stabilization Unit, all of those were components that brought together what we're doing and trying to replicate statewide. Each county is doing it a little bit differently. We're seeing tremendous successes in counties such as Clay County. Brevard is really starting to move forward. And we've reached out to some of the very remote rural communities as well, and we're seeing successes there. But what I wanted to share with the group is, and I know that Dr. Phillips alluded to it a little bit, but we're approaching this in a different way, and we're utilizing the EMS providers statewide with a protocol that Dr. Phillips and I refined, and it's a protocol that allows the paramedics when engaging with a patient of a recent overdose that's been reversed by Narcan and shows signs of opioid use, that if they're willing, pre-hospital, we will be inducing the patients with a high dose of buprenorphine. And what this does is it prevents the patient from going into a significant precipitated withdrawal. And by delivering a patient to the hospital with a clear sense of thought and not in pain, they're more receptive to receiving treatment and therapy that would be ongoing. So the goal there would be then to connect them with the community services that have been already established, some with the Bridge program with DCF, some with the CORE program, and others that we're working on. The results of these types of treatment paradigms are being seen in New Jersey and in California with great success. And we believe that this will be the next wave of how do we treat patients, prevent them from walking out of the emergency room, and to make them more receptive to receiving training, or not training, but care. And I do want to mention that this is not the only method, because it's not right for everybody. So by engaging with our patients early and trying to streamline them into facilities that have addiction specialists, the main goal is that we get the best care for each patient on an individualized basis that's medically directed and scientifically data proven. So that's what we're doing. We're getting ready to implement 17 more counties. And as Dr. Shupke mentions on a regular basis, the goal is to have all 65 counties on board as quickly as we can move forward with it.
Great. Any questions? Any, yes, Whitney Van Arsdale. I see you have your hand up.
No questions, sorry.
What?
She said no.
Oh, okay. Any questions of Houston? Awesome. Thank you, Houston. Keep up the good work, and let you know. I imagine that you're going to be because these are all new. These are the Addiction Stabilization Unit in Palm Beach County has been in operation for several years, so we're able to see some data. I would imagine that we'll begin to see some data from these other new stabilization units around the state. So please let me know when you have updates on this so you can keep us informed. And thank you very much for the presentation.
You're welcome. I just wanted to also add that, again, Palm Beach County is setting the bar. And so the protocol that we helped develop, they are getting ready to implement. And so Palm Beach County will be one of the first in the state, if not the first, to be doing pre-hospital induction of buprenorphine. And I do want to mention that the program with CORE is not specifically related to opioids. We are encompassing all of substance use disorders and providing avenues of treatment for the various types of addictions that have known medical assisted treatment. And then with that, also continuing to support the behavioral health side of it.
Houston, you may not have an answer to this, but do you see an influx of money coming, dollars coming from either SOAR or the opioid settlements into this model to all the operations throughout the state, including Palm Beach County?
Yes, absolutely. So the opioid settlement funds are being distributed in some parts of the state. They will go directly through the counties, and then in other parts, they'll be managed through DCF. So there will be a significant amount of money that's coming in, and part of that money will be for sustainment for a long period of time, and also to support EMS needs for funding Suboxone in the field.
And one other question, and this is kind of like, I'm positing this because housing is such a critical component of recovery. If there were a way to partner FAR with these 12 and 14 and expanding models where for opioid use disorder, because specifically that's what we're talking about with the MAT protocols, so that perhaps they can become a partner and we can free up some dollars for housing as well.
Yeah, I know that they've included the Oxford model in the OD2A grants. That's a federal grant that's coming down, and that's also been identified as a funding source that will continue. And the track record of FAR is very important because, you know, at least having a certification to a home or a facility gives it support compared to what we've seen, and part of the reason that this Sober Home Task Force was created.
Okay, thank you. This kind of is going to segue into the housing proviso for grant for a study, and also looking back to what Michael Cabot said about defining level 4, level 3, and perhaps we can all think about ways that we can influence legislation to make it a little easier, for lack of a better term, to get insurance companies, maybe through Medicare and Medicaid rules for opioid use disorder, to get housing into especially level 4 housing, which would be your partial hospitalization or your day-night Florida model, to get housing to be reimbursable. In which case we would solve a lot of problems. Patient brokering, for example, the issue of free rent. When somebody's in an intensive outpatient program for 25 hours a week, if the housing could be included in the treatment matrix, then we might resolve a number of problems and encourage the long-term recovery by including the housing as a standard factor. So anyway, that's kind of expanding what you were saying, but these are the things we have to look toward rather than just do that separate silo, even if it's combined silo of the induction into treatment and then giving them a warm handoff. Well, let's goose the warm handoff a little bit so that we can encourage longer term hands-on. So anyway, thank you, Houston. Seeing no questions, let's move on to the legislation. As I said, the fentanyl test strip legislation, the Senate bill is in messages. What that means for you folks who are not lobbyists or politicians is that it was passed by the Senate. It's now sent over to the House to accept and vote. Once the House votes on it, it will become law. I want to commend Maureen Keelian in bringing up the fact that we should have an exemption for testing for the xylazine, but that's another fight for another day. We can try to amend it to add that next year. But encouraging news this year, cross your fingers, it ain't a done deal. It was killed last year in the Senate. Never got called up for a vote. It was stripped out of the Senate bill. So we're doing well. The House passed it unanimously. Hopefully the House will call it up for a vote and we'll have that fentanyl test strip exemption so people can test their cocaine to make sure there's no fentanyl in their drug, or marijuana or Adderall. Moving on to 6B, which is our bill, the Saartf bill. Senate Bill 210 is also in messages. So the bill has been passed, waiting for the House to bring it to the floor to vote. We're highly optimistic. I spoke to Representative Caruso's staff, and Walter told me that they're expecting that it'll be called up next week. I don't want to jinx it, probably already did, but hopefully that will be passed as well. Going to 6C, which I think we need to have a bit of a conversation about. Both the Senate and the House have filed the proviso study. As you remember, the proviso study is to try to standardize the way communities look at recovery residences. I mean, there'll be some rules, but there'll also be some automatic zoning allowances in communities, provided these houses aren't in districts. There's some separation, but it's a group house study. We get to input into the study, or at least to the person who is likely to do the study, in terms of on the boots on the ground, what we need to do to make sure, number one, as Lori brought up, winning over the community. Certified recovery residences and Oxford houses are beneficial to a community, and they're not blights on the community. like the old flop houses were in Delray Beach. So, having them come along, having the local governments come along and adopt these ordinances, provided they're not discriminatory, that I think would bring us all together in the same direction. So, we don't know what's going to get cut out of the budget. Right now, it's in the budget because it's been filed, and they're going to do their magic, pulling rabbits out of their hat. And hopefully we won't wind up on the cutting room floor. But anyway, anybody have any comments, questions about any of the legislation, including the proviso study? And Carol, do you have anything you'd like to add? Oh, wait, I see Michael Cabot, you've got your hand up, please.
I do, Al. A question. You and I had a conversation about medical marijuana in recovery residences. What bill is addressing that issue?
That's SB 210, which is our bill out of this State Attorney Addiction Recovery Task Force.
Okay, perfect.
It basically says marijuana is for FAR as well as for any treatment provider housing is forbidden, just like alcohol is, and just like prescription drugs without a prescription. Medical marijuana cannot be prescribed because it's illegal federally. It's not FDA approved. So therefore, there'll be a ban on marijuana in the housing that is referred to or accepting referrals from a provider or owned by a provider, as well as facilities. So yeah, Austin, you have a question or a comment?
Yeah, my initial comment, and then I guess I'd like to follow up on that last thing as well. But as far as the fentanyl test strips go, I recognize, like as you had said, Al, it's been a long and ongoing battle and continues to die in the House or in some, I think it was criminal justice committee last year. So it's great that we have this coming up and hopefully will pass, but I just want to caution. I think that limiting it, having it as an exception of just being fentanyl is still going to be problematic. I think efforts in terms of advocacy and lobbying need to go towards a language change as a whole that defines any drug checking equipment being paraphernalia. When we specify something like fentanyl, I mean, we saw like towards the beginning of this meeting, fentanyl's kind of becoming one of the lesser concerns when we have nitazines and xylazine showing up. I know it's like an ongoing thing and something, maybe next legislative session, but next legislative session, xylazine might not be the only problem. I just fear that we will kind of peg ourselves into a hole that we're always trying to catch up on. Whereas if we could have a expanded drug checking program throughout Palm Beach County, throughout Florida, that allows drug checking for all sorts of contaminants, including fentanyl and fentanyl analogs, that would be more advantageous towards the safety of people who use drugs. I think limiting it to fentanyl, and if it even more so, if it limits it only to fentanyl test strips, we're kind of continuing to present the same battles that we're having to fight. And I don't know, I caution against limiting ourselves. But the other thing is that House bill with the medical marijuana, is that like a sure thing? Is that like to go through? That's said and done?
If the House picks it up and votes on it, yes.
Okay.
Yeah, Austin, that was a point well taken, by the way. We constantly are playing catch up with new and novel chemistry. And there's nothing, law enforcement is in the same trick bag. I mean, kratom is a drug that's killing people. So, it's kind of like the half a loaf idea. This I've always been governed by, perfection is the enemy of the good. So you know, it's good that we can make strides. We have a very conservative legislature. So we had to hammer this out. It's not just fentanyl, it's any fentanyl analog. And it's also fentanyl analogs that haven't been invented yet, but they are of the fentanyl family. I agree with you that we may have to go back when we identify non-opioid type problems like the xylazine. But hey, that's a battle for another day. Any other comments? I do want to, in June, we're going to start the discussion, couple of discussions. Number one, I had mentioned about level 4 and about how to achieve universal coverage of housing as part of the treatment package. So that's one thing where, what can we do? You know, I'm hoping to talk to the folks at FSAM, Dr. Simonides, about, you know, maybe we can come up with something, and maybe we can come up with something as a group. And number 2, regarding housing, we need to, well, anyway, let me just leave it at that. We are going to be coming up with some game changers. The second thing I want everybody to think about has nothing to do with housing per se, but it was one of the first things for those of you who've been with us since July of 2016. One of the first things we discussed was ACA taking over behavioral health. 40 years ago, it was kind of like, well, there was discrimination in healthcare. There wasn't parity. Well, there still isn't, but at least the law recognizes parity. And 40 years ago, it was like, what do we do with people who have mental problems or have drug problems? And this state determined that it wasn't a health problem, it was a family problem. And 40, 50 years ago, that was the bias, that was the discrimination that was going on. There is no justification for ACA, for Department of Health, not to be in charge of behavioral health. I haven't heard any, and maybe somebody out there has, and we can discuss this. Well, let's start the discussion on whether we can get traction to get ACA to take over behavioral health, the actual clinical medical side of behavioral health. Anyway, thoughts for next time. Let's move on to Dr. Annie Peters, the Foundation for Recovery Science and Education, and it's F small o, capital R, capital C, capital E. I kind of butchered that in the first agenda. We corrected that, so my bad. But Annie, you want to share the screen, or do you want us to put the screen up for you?
Either way, what's easier for you? Want me to just put it up?
Oh, what's that? Oh, we never got your PowerPoint. So
Oh, I thought I
and
sent
please, and please, if you would send it to us so we can send it
it.
out.
I sure will. Can you see my screen?
And see your screen.
Excellent. All right. Well, there's a number of slides here, but I'm going to try to get through them quickly because really what I just want to do is introduce myself. I know some of you have seen me before on this meeting or elsewhere. And I just want to let you know about FORCE and what FORCE is doing and what NAATP is doing around addiction and outcomes. And it's a really exciting program that I want to let you know where we are with it. So who I am, I'm Dr. Annie Peters. I am a clinical psychologist. I've been primarily in the field of addiction treatment of some type, some level on the continuum of care as a clinical leader or clinician for since the beginning of my career, which was in early 2000s. And now I work for the National Association of Addiction Treatment Providers, which has been around since the 1970s and was originally formed by mainly 12-step oriented residential treatment programs, but has expanded and now has a lot of members that are anything from outpatient MOUD providers to recovery residences, to recovery coaches, all kinds of different types of members. And what NAATP does is support those members in advocacy and quality. And one of the main things we've been hearing for a long time is that we need help with demonstrating quality, and we need to really transition to value-based care and demonstrating to the public, to policymakers that and to payers that our services, whatever they are on the continuum of care, are valuable and worth the cost. So FORCE was developed, the NAATP Foundation for Recovery Science and Education. We created a separate entity so it could be a 501c3 so that we would be able to receive grants and funding that NAATP is a nonprofit, but it's not a 501c3. So FORCE has been around since 2020, and I was hired primarily to do this work. And so that is what I focus on, is running the FORCE Addiction Treatment Outcomes Program, which I'll talk about in a minute. This is just a summary of all the problems there's more than this, but some major challenges in addiction healthcare, and in demonstrating that there is an evidence base for addiction care is, if we were all part of one health system that was reimbursed well, and parity was strong, and we had equity, all of these issues, and there was less stigma, all of those issues are the challenges that make addiction services, whatever they are, whether it's a recovery residence or a treatment center, questioned by the public and by stakeholders, because we don't have biomarkers like other illnesses do. We don't have standardized measures of quality. We don't have a blood pressure cuff. We're not integrated. We're all fragmented, and there's not a lot of faith in addiction services. So, and a lot of programs that have been around for a really long time have relied on anecdotal evidence, but that anecdotal evidence is very strong. Some have tens of thousands of alumni who are living healthy, well lives, and have transformed their lives, and are part of communities now that and are really valuable to their families and thrive. But we don't have a lot of evidence of that, and that story has largely not been told. The focus primarily for the past few decades has been on medications, as it needs to be for particularly for the opioid epidemic and for trying to reduce overdose and reduce early death. But there's more to the recovery story, as I know you all know and believe in. So how do we do that? How do we determine if treatment or recovery support or recovery residence, how do we determine it's effective? We're asked a lot in what's your success rate? And most of us can't answer that with a number. So that's a challenge. We can't say, and there's not a standard measure. It's not abstinence anymore. That's, not the gold standard everyone agrees on. It's primary, it's reduction in use, of course, and reduction in consequences of use. But really what we need to know as a field is what works, who needs what and when. So, and what I mean by what is, we know we can't pick necessarily down to, does this person need motivational interviewing or cognitive behavioral therapy, but we need to be able to know what level of care the person needs, how long they need treatment or recovery support, what kind of recovery support they need, what medications they need. And we need to be able to track their outcomes, their substance use outcomes, their functioning, their physical and their mental health, and their quality of life. And if we knew even just those, how many are on there, 12 indicators, if we could have one question for each of those, which is a challenge. We can't measure demographics in one question, for example, or mental health or social determinants. But if we were able to narrow it down and measure these things across different types of care, it would be unbelievable to the field. So there's a grassroots kind of effort that formed, it's through NAATP, but I think of it as grassroots because it's primarily providers who say we have to raise the floor on how people perceive treatment and how people perceive recovery. So So we created Force, and we said the future of addiction healthcare really is in data that we collect. We know data is really king nowadays, or queen. And we know that providers of any type of service have to demonstrate that what they're doing is effective. And so what Force does is, for no charge, we offer our support and guidance around outcomes measurement. So if someone, we consult really largely for free. And at this point, we're all run by donations and grants. And of course, we're starting a new fundraising campaign this year and hope to get more support. But right now, the major piece we've been working on is developing this database of those indicators from that previous slide, of demographics, who is served where, and what kinds of outcomes we observe. So we have a data repository that was designed by providers, is driven by providers, and we're run by a 501c3 that was created by NATP, which is a trade association with 40 years really of attention to ethics in the field. And we really focus on social determinants, health equity and inclusion in how we collect data and how we use data, trying to determine who needs what and when. And we're able to collect data across multiple pathways to recovery, whether you just offer medication services, you offer 12 steps, you offer recovery support, recovery housing, whatever. If you use some of the common measures, we can take the data. It's all fully de-identified data, so it removes the question of patient privacy. And we then develop reports, which we give back to each provider. So we're only maybe 2 weeks or so out from publishing our first national aggregate report, summarizing across all of our providers that are sending data. It's exciting. It's going to be fabulous. I've seen the drafts. It's going to be really amazing because it's something like we've never seen before. This level of collaboration across the field. And then following that report, each participating service provider will receive their own mini report summarizing their outcomes so that then they can compare that to the aggregate report. As Nikki Soto is on this call and I have done, we've talked about how this data can then be used for advocacy, to support parity, to support equity, to support access to services, and to demonstrate value of treatment and recovery support services. So how do we do it? This is how we're doing it. Essentially, if you collect data electronically, it can be shared with us. We just have to find the way to connect. The easiest way, of course, is an electronic health record. If you don't use one of those, if you use a mobile app of some kind, or any kind of online portal, any tech way to collect data from patients, through application programming interface, we can accept that data and then provide reports and also generate research studies. And so these are the partners we have now. So Sigmund Software, Kipu, Lightning Step, Best Notes, those are our EMRs that are fully connected to us. Petrie Consulting and ERP Health have mobile apps or online portals to collect data. We also have a number in progress. There's actually been 2 more since I wrote that slide. So Preta and Behavior with an AI. Those 2, as well as those ones on there, are in the process of working on connecting with us. And so Sunwave is almost done. They're very close to finishing. So we rely on these providers to write the plugin to our database so that this is not on the provider. We really rely on tech vendors. And if folks use a different vendor, we're happy to talk to them and have had very successful conversations, with a lot of vendors who really want to support what we're doing and are willing to do that without charging their customers. That's our glitch. We say, we want to connect with you. We want to put you on a slide like this. and talk about you and how great you are because you're doing this great work. But you need to not charge your providers to do this work. We've been successful with that so far. And these are the treatment centers and recovery centers that are participating. So there's 73 of them as of today. As you look at that list, you'll see there's some very large ones you might recognize: Gateway Foundation, Recovery Centers of America, Caron Foundation. We have lots of sites in Florida, and we're growing all the time. I'm having conversations with these programs all the time. Some have been doing outcomes measurement since, decades ago, and some are just starting or just opened. We have some that there's one on here that's 80 years old and has been doing treatment since that time. And there's one that's has about 2 patients right now. So this is the content of the database. We have 170,000 unique patient episodes of care. So that's a lot of different people being treated in different settings. Our most commonly used outcome measures are the PHQ-9, the GAD-7, the BAM, and our own Force Outcomes Survey. You may recognize some of those. Some of those are not addiction surveys. The PHQ-9 is our most popular, and it's a depression screen. But if we can show that addiction treatment helps depression decrease, that's great. I want to just show you this. These are our measures, but so we collect data at both during services and post services. But I kind of want to get to some of the findings, and I don't want to take too much of your time here. I know you have a busy schedule. So we take data from both time points. You do not have to measure at those exact time points, which causes messy data, but we are able to clump the data into buckets and do the best comparisons we have or we can do. This is an internal dashboard that has not been made public yet, but this is a picture from a recovery program that I just wanted to show kind of what's possible with this program that we're doing. If you look at discharge type there on the left, you'll see that the dark blue is the completed percentage of completed treatment. So not ASA, not any other type of discharge, but treatment completion. And you'll see that this particular treatment center has a higher completion rate than the average, a much lower ASA rate. That's a really valuable piece of information for that hasn't been really available. It's not in the National Survey of Drug Use and Health, doesn't break down data like this, doesn't provide data with comparisons back to each individual program. So this is a new type of service that is really exciting to providers. And we have lots of different ways to filter the data and look at the data. And we're going to be making this dashboard available later this year. But I want to show you some of the findings. Probably the first finding we're seeing is that the data are messy. And we could have guessed this, but how messy is it? Very, because even with just age, gender, and race, we do not collect those in the same way. There's still a number of EMRs that have male, female, and other as gender options, and that's it. And we have some that have very limited race and ethnicity options. So as you can see here, this was a data pool from a while back, but half the data had to be cleaned out because we didn't have these data points. So we've done a lot of data validation and work with the EMRs and the tech vendors to clean this up since then. But we're finding that standardization is such a huge problem for any of these. Just a couple other things. We see here, alcohol is the most commonly treated substance use disorder across all different, across all the participating organizations. But, when it gets down to residential, it's 63% is alcohol in residential treatment. We're finding interesting things like, for example, you see in the yellow there, 57% of clients with opioid use disorder are receiving inpatient or detox only, and that's it. So they're getting detoxed. which we know the evidence around detoxing people with an opioid use disorder is not good. That's a frightening thing to find. And so these are some realities that, we're starting to see. Another one is treatment completion. If you look at inpatient detox and residential, the treatment completion, which is the green, is pretty high. When we look at outpatient, the AMA rate is, at least among our sample, is quite high, the AMA rate for outpatient. So this is a big challenge too. If people are leaving, if we find this as we move forward, that people are much more frequently leaving outpatient, which makes sense, but there's some scary things in here. Wanted to give some good news. This is a small sample. This is a sample of the folks that use the FORCE outcomes survey, which is a 10-question survey that covers a lot of different pieces of kind of related to the NOMs, the national outcome measures, but there is a question on relapse. So that's not appropriate for everyone. Not everyone wants to talk about relapse. They want to talk about return to dangerous use or something like that. But those who are tracking relapse, so this is 1,200 patients, what we're finding is that those who, and we would have guessed this, right? Those who leave AMA are on average 2.65 times more likely to relapse. We're seeing a big difference between people who stay less than 8 days in any kind of service, being at least double, more than double likely to relapse. So these are some exciting things. We're also, this, and the last slide I have here is just reduction in PHQ and GAD. So you can see the red line is from the first measure to the last. So PHQ at admission and PHQ, the last PHQ they take. There's not much change, measurable change in those who discharge AMA or other types of irregular discharge, but those who complete treatment across levels of care can lead up to a 50% improvement in mood. These are stories that have not been told. They've been told in research studies. This is not human subjects research, so it's not as rigorous, but it's telling stories that have not been told before, and it's arming providers with information so that they can do what they do better and hopefully serve more people. So next steps are ongoing, and there's very easy steps to participation. You can, if anyone on here is interested or know a program that might be interested, let me know. As I said, there's no cost to participate, especially if you use one of those vendors. You won't have to worry about anything at all. If it's a vendor that's not on the list there, then the challenge is just time. It takes them a while to get connected. That's my contact information, and happy to answer any questions. I hope that was a really fast overview, but I wanted to kind of get to the meat, and I thank you for your time.
Thank you, Annie. And I guess it sounds like we'll need to bring you back in either June or August, because your big report's coming out in 2 weeks.
Yep.
Kind of brought you in a little bit too soon.
No problem. Yeah.
But it's still good to have you, and this is very important stuff. Can you give us some examples of what you foresee as a practical application of the program?
Yeah. First and foremost is the value it gives to the provider. Is the provider will have a document that they can use in contracting conversations with payers. They can use it for marketing. Now we have a lot of caveats in these reports, saying this is not a research study, a rigorous research study. And so there's a long list of caveats about the data, and the analyses that are done, but it's a starting point. One of the things I think someone asked me, a treatment center asked me recently, what are the differences in my, the racial groups of my patients and their discharge types. And as they suspected, their Black or African-American patients, their AMA rate was double that of their white patients, which is what they were afraid of. So that is helpful to them as far as process improvement. And so the next steps is we're working on research partnerships now. We need to get cleaner studies that are more rigorous, in design. And so research partnerships is a major deal. And once we get, working toward publication, peer-reviewed journal articles are really the currency with which we always say this, buy our rightful place in healthcare, as we need to publish good or valid research on treatment and on treatment as it is. We have it as practice-based evidence, but we need to, bring the evidence forward so that it can be used in policy discussions, in discussions with families, and discussions with payers. So there's lots of applications and promise to it, but we are at the early stages.
Okay, I see Jeff Lynn, you have your hand up.
I do. Hi, Dr. Peters. It's a pleasure meeting you.
Yes.
I'm very familiar with your program.
Oh, great.
And I don't know if this is a question better suited for Nikki and or you. Does NATAP have any policy or desire or intention to take the evidence-based outcome data and start sitting down, as you said, with payers, with like the insurance companies? Because what ends up happening is it has to be done on at least for I represent treatment providers, so it ends up having to be done on a provider by provider basis. And I'll use a bad example, like we all know equine therapy works. I'm not saying that, but let's pick a modality, and pick a modality that you're finding and NATAP's finding, okay, this is working. Is there any movement towards being the membership organization that NATAP is to maybe have those conversations, being that you're a larger industry player with the insurance providers, to have that conversation?
Mm-hmm. Yep, we have an advisory group that has a number of payers on it. We have one particular group of payers that's a membership association of payers that we're working on a research partnership, which would be really exciting. And so we want to have those conversations. We think they probably will first occur on a provider level, but we're doing our best to get connected to the right people. And so, we've had some luck, but I think as our report comes out, hopefully there'll be more interest and we'll get the word out there. I thought you were going to ask about, will we be sitting in front of policymakers? And I thought that would be a question Nikki would answer, because I'm hopeful that we just did a webinar on how.
That was actually my second question.
Okay.
Follow-up was going to be with all of the continued, and I pester Al with this, continued push towards making parity an actual reality instead of just words on a paper, whether what you guys are doing could further that conversation even more.
I mean, that's our hope, that we absolutely intend to do that. And as Annie was getting ready to say, that our hope, well, it's not even our hope. What we're trying to do is we're going to be able to use this data to put in front of policymakers to show them these outcomes, and not only policymakers, Jeffrey, too, the payers, to say, this is what you are going to get. And so these are the results that we're seeing. And so yes, to both of your questions, this is going to have a big impact on policy, and those payers have been invited to come and be part of these conversations. And I think that we're getting closer and closer to be able to have some real results from them.
Thanks.
Hey, Susan, you had your hand up? You got to unmute yourself.
I did. I'm muted. I'm not fast enough on the draw. Anyway, I'm Dr. Peters. I am also very excited to see you here, and I'm already a big fan of Nikki and her very large dog. But I am, and I may have missed this, but I'm on the other side of it. So I've been known to sue treatment providers, just FYI. And one of the issues has been, can you explain to me what you are, you may say something on your website about, like, we have a 90%
success rate.
And then when you drill down to that, it's 90% of those who volunteer to participate in the follow-up at 60 days.
Yeah.
So you're telling me it's only 90% of 10 patients. I mean, like,
exactly.
It's not. So one of the things I think you said is, I mean, the data that you are all collecting is coming directly from the electronic health record. It's not the provider telling you, it's you are given access to the actual patient data.
We are.
Okay, so the middleman is out in some sense.
Yeah.
Right, so
There's-
the data is more reliable.
Yes, they could enter false.
Okay, assuming we don't have that. Okay.
Assuming we don't have that.
Right.
We get the
Assuming the
actual,
marketing directors are not giving you the data, it's actually coming from clinical people.
Yeah.
But
which is
you're
also
not-
why we say in our contract with them that they can't just take like a piece of their report and market with it. They have to run their marketing past us, because when we
Excellent.
give reports, it will have all of that about response rate, post-discharge response rate, and number of respondents and things like that. But if we don't want them to take a screenshot and put that on your website and say, oh, look, we have a 90% success rate. So we've been very
that's fabulous.
cautious about that.
Yeah,
'cause
that
we
would
are-
be my cautionary tale. I mean, on the other hand of it, and I may not be the sharpest knife in the draw, but I'm pretty sure like we wouldn't take people's gallbladders out unless there was evidence that a cholecystectomy would solve your problem. In this space, we don't have that kind of data. So I am really, if I can do something, you let me know, because I think this is what FAR is trying to do, and with recovery, capital indexing, and all that kind of stuff. So that's great. Thank you, Lee.
Thank you so much.
I want to follow up with those questions and basically ask you a question regarding the research partnerships and payers.
Yeah.
Again, those of you who were back in the Precambrian days, in 2017 and 18, we actually had state vice presidents of an insurance company, Cigna, Blue, show up to a task force meeting and then never come back. I actually did some presentations with one of them who basically, when I talked about housing, I've been talking about the critical nature of housing in recovery, and the counterproductiveness of having people in 25 hours a week treatment who don't have a job being required to pay for housing while they're in treatment. You have PHP, it's an alternative to hospitalization. Okay. And invariably they would say, show me the data and we'll change our ways. And one of them, and I think it was Cigna, I'll have to look because I want to start inviting them back, said that they're doing a pilot project. But here's where perhaps when you talk about collaborations and partnerships, getting parity is going to be the ultimate prize. Okay, sitting down with policymakers, parity is the rainbow stew of what we do, right? But something as critical as housing in, say, a level 4 context, where they're going 25 hours a week, they meaning the patient is going 25 hours a week to an intensive program. And many of them, if not most of them, because of their status as being an opioid use disorder patient, they don't have a job. They don't have an income. And if they don't have a family member going to float the bill, and that's why we get into trouble. So can we translate the data you're collecting or use it along with the recovery capital that we've been talking about earlier on with FAR, for example, to get some peer review studies that can move the bar with regard to the payers, the insurance
I
company?
certainly hope so. And we have the RCI, which is powered by Glue. They are willing to connect to our system if you use the RCI, the Recovery Capital Index. The one we have in our system that a lot of our folks are using is the BARC, the Brief Assessment of Recovery Capital. So if you just use the BARC, because it's free, we put only free ones in our thing. So if you're using the BARC and you want to follow your outcomes, join, and we can, I mean, that's the power of the collaborative, is that one center collecting their data is not as powerful when you have 73 and, we're hoping to get to 100 by the end of the year at least. Then you start to get a lot more interest in, this is actual data coming from folks who are having a measurable impact on recovery capital, on mental health symptoms, and quality of life. We imagine people will start to pay attention, and we're going to do our best to be loud about it.
So can say, and I know they're not treatment providers, obviously, because they're not clinical, but can forest certified programs join force?
Yeah, the only challenge is how to get the data to us. If you don't have an EMR, we'd have to go through some sort of app. And so if there's an app you use, talk to us, get us in contact with them. Let's try to figure it out. It's not a hard connection if you're a software developer. I've heard the developers that have worked on this said, oh, your documentation is really easy. This was really easy to do, but you got to get them to do it. And so that's sometimes takes some time.
Well, Susan, Michael, Heidi, this is something that you all ought to discuss.
And even if you just want to get our report, send me an email. I'll put you on our list to get our report.
Awesome. Yeah. And we will be talking about this in terms of potential legislation here in Florida. But I think that the second thing is, how can we get the insurance companies to start reimbursing for level 4? Let's start with level 4. I get again, the rainbow stew is all housing of people who are in recovery in any kind of intensive outpatient program, level 2, 3, or 4. But if we start with 4, which is the highest level of intensive outpatient, and it's 25 hours a week, and we talk about the reality of housing being critical to recovery, and we have some data to back that up, maybe we can get some of the insurance companies to figure out that it actually is cost effective.
Yeah.
Okay, any other questions? Thank you, Dr. Peters. Thank you so much.
Absolutely. Thank you all for your time.
And let's move on to the OD2A update. Whitney Van Arsdale, thank you for being so patient.
Yeah. Hi, everyone. Do you guys have my slides or you want me to pull them up?
I have them.
Okay, we'll pull them up for you.
Give me 1 minute, you're on the end.
There it is.
There you go.
All right. Okay. Just go ahead to the next slide, please. So updates from OD2A in Palm Beach County. We have finished our collection and abstraction of 2022 non-fatal data. We ended up with over 1,500 records. I'm not sure the exact number at the moment, but we continued to expand our surveillance to include not only opioids and psychostimulants like we did in 2021, but also benzodiazepines, some other sedatives, hallucinogens, psychedelics, and then any other illicit substances of concern like xylazine, kratom, things like that. We are in the process of going through the 2022 fatal data, working with the medical examiner to make sure we got all related overdoses as well. Next slide, please. So typically after we look at our data sample for the year, especially for our non-fatal overdoses, we start asking questions about, which hospitals, which regions they came from. Is this representative of the whole population? So here on this slide is a few things. The biggest one being the suspected overdoses by hospital for 2022. There's 2 different queries that we use to pull this data. And this is our syndromic surveillance data from the Essence, Florida. So this gives us some estimates about how many potential overdoses the hospital saw last year. You can see JFK Maine was the highest, and it goes all the way down to Bethesda West. The reason that numbers are so different from the old query to the new query when we're looking at the syndromic definition is that the old query was much more sensitive, meaning that it tried to include as many possible overdoses, but on the flip side, it's going to include some cases that are not a true overdose, maybe substance use or withdrawal, or a few of those false positives might get in there. So Essence updated their definition to make it more specific, and so that's why you see the change in numbers. Next slide, please. So here we're looking at the estimated number of records that they received as a percentage, and the percent that we actually were able to collect. So we work with a lot of hospitals in Palm Beach County, and they're highlighted in blue. And so you can see those percentage of records collected are much higher. JFK North, we had well over 100%. Essentially, that's probably because they're coming from JFK Main and getting transferred to JFK North or whatever the process is. And we pick up those records from JFK North. Some hospitals, we physically go and pick up records. Sometimes they send it to us with secure email or fax. Sometimes we request records and we receive it that way. So we're kind of just working with all the hospitals to try to make it as easy as possible on them while getting the most data on our end. So we start to request hospitals because Essence is de-identified data, which is great. It provides a near real-time snapshot of what's going on. So it's really good for monitoring spikes. But it only provides the basic demographics such as age, sex, race, and then you only get very limited data on chief complaints and discharge diagnosis. So we don't really know what's going on with the patient, social determinants of health, linkages to care. We don't really get a lot of that data when we just rely on this Essence syndromic surveillance data, which is why we request the medical records. Next slide, please. So again, we're trying to get medical records so that we can look at this whole person perspective. I feel like this was a great setup from Dr. Peters coming in here. We collect a lot of the same, we're trying to collect a lot of the same things, these social determinants of health, if they have health insurance, if they have housing stability or instability, their employment status, occupational industries, types of substances they use. Like, we really need that lab toxicology so that we can better identify what's going on in our county. We see a lot of potentially laced or contaminated substances, so that's a great way to monitor for that, as well as the methods of use like injection drug use and emerging threats such as xylazine, gas station heroin, which is a antidepressant that can cause opioid-like withdrawal symptoms, as well as like kratom, press pills, etc. We also monitor for outcomes, so we're looking at complications, including organ failure, rhabdomyolysis, encephalopathy, anoxic brain injury, of course, death, all these different outcomes that can relate to the severity of the overdose, as well as discharge disposition. We're looking to see, are they discharged into a facility for treatment? Are they discharged to police custody? Do they leave AMA? We like to do a lot of that racial stratification as well. So we're looking at this by race. Harm reduction services, are they getting linked to treatment? How often are they reporting any barriers to treatment? A lot of times in the medical records, we'll see that they were interested in getting treatment, but they had to be at their job tomorrow, or they didn't have anybody to watch their kids, or all these different barriers that we try to measure and report to the community so that we can better plan our resources. Comorbidities, co-occurring disorders, so everything from hepatitis vaccines to mental health, a lot of these comorbidities that come along with it as well. And then, of course, recurrent overdoses. Patient level data is really the only effective way to study recurrent overdose and to be able to track outcomes, linkages to care, and how that affects a person's likelihood of having a repeat overdose. Next slide. So without that really good medical record, patient level data, we have to rely on these kind of overview trends, which are, like I said, they're very helpful. So we have some EMS ones on the left and ED visits on the right. Both 2022 and 2023, we can see that it decreased from last year. But this quarter saw a rise towards the end. And again, this is the syndromic surveillance, so it doesn't really go into a lot of detail. We're not getting the full picture without those medical records to correspond to this. Next slide, please. Here is the suspected overdose visits for the first 3 months of the year from the emergency department, broken down by substance. We have these opioids groups, stimulants, and then this other category called unspecified. And unspecified overdoses are in the syndromic surveillance, where the line just says overdose, and it doesn't give us any kind of clue about what kind of overdose it was or what kind of drugs they took. So we just call it unspecified. It's probably that a large portion of those unspecified are actually opioid overdoses, but just based on this essence data, we can't really quantify and tell. Next slide, please. And then finally, I talked a little bit about Kratom last week, and we did a little bit more digging into it, and we made this heat map for Kratom-involved overdose deaths in 2021. We had the highest density in the Boynton Beach and Delray Beach area, which is a little bit different because normally we see a lot of our overdoses Lake Worth and West Palm, but for Kratom it was concentrated more in the south. And then to the right of that, we have a line chart for Kratom-involved overdose deaths by quarter, with the caveat that 2022 data is not finalized and 2023 data is definitely not finalized. So those are subject to change, but it really spiked in that last quarter of 2021. Most of the Kratom deaths were polysubstance, 95% were polysubstance related. And of those, 99% involved opioids, primarily fentanyl, acetylfentanyl, some fluorofentanyl. And then we also had about a third involving cocaine, and then 17% involving amphetamines, primarily prescription amphetamines, followed by methamphetamine. And next slide. And we're also working on a few new things. You know, this phase of the grant is coming to an end in a couple months, but we're reapplying for a new 5-year grant. Cautiously optimistic that we will be receiving the grant. We're working on a surveillance dashboard to bring you a lot of this data in a creative way where you can interact with it and kind of pull your own data for your program. We're also working on our annual reports, both non-fatal and fatal data, so I'll be getting those out to you guys as soon as I can. Thank you.
Any questions, comments? I know the last time, Whitney, that you presented, you didn't have 100% participation in the hospitals. Are you there yet?
No, where we left off, our legal team was working with JFK Maine, and I know that the MOA got sent over to us, but I think there was a problem on our legal side that they couldn't accept some of the language in there. So that has been in legal purgatory. Bethesda's, we have not been able to get an audience with, or at least I and Natalie have not been able to. And then some of the other hospitals, you'll see on slide 4. On slide 4, even some of the hospitals that we do partner with, we're not getting everything that we think we should be getting, but we are getting some from them. So it's It's been kind of like a hodgepodge. We're just trying to work with them to get the data, whatever way we can. So we're open for collaborations and, working
I
together.
mean, JFK, they're a significant facility when it comes to OD visits for overdose. And that,
JFK Main and Bethesda
yeah,
East are always like neck and neck for overdose visits.
and that kind of explains the graph that you had where you didn't have data. You knew the number because I guess you have alternative ways of finding out from fire rescue, et cetera. You knew the number, but you didn't have data in there.
Yeah, like we can get an estimate of how many we should have gotten, and then we know how many we did receive. So we can kind of do that math.
Off the record, of course, we're on the record. And I know you can't do this, working for, well, you're Palm Beach County, right?
Yeah, FDOH.
Yeah, the FDOH, okay. So what can we do? I mean, there should be a hammer for hospitals it should be in their best interest to cooperate. Not calling any particular hospital out, but I thought that there was some grant money or something that required them to be cooperative in terms of data sharing. I guess there are no state laws that require it, but maybe we need to look into that for next year. If this is a 5-year, and luck be with you, I know we're supporting you here at the state attorney's office for the 5-year grant, but we need to figure out how to get better response from the hospitals, the local hospitals. And maybe, I don't know, somebody's on our task force can just contact me and say, okay, well, here's the statute that we need to amend to require or make it somehow use a carrot and stick approach, because you're doing great work, but you're doing it with one hand tied behind your back. So
We get creative.
you're still factual, so you need as much data as you can have.
Yeah.
And so I want everybody to think about this, because this should not happen.
I just wanted to say something.
Yes,
along those lines. I think that the data dashboard is genius. I think that if everyone can see the data that you're collecting and what you're doing and exactly the populations and the areas that are spiking and so on and so forth, I think that that would definitely give you the validity and credibility maybe to the hospitals so that they are more cooperative. I think that if they have that if they see the visibility like that, and people are actually using your data dashboard, I think that would be incredible. That's all I have to say.
I will say we were really excited last summer hearing that there was a statute that came out that mandated the reporting of controlled substance overdoses. However, after reviewing it, the language, it seems like it applies to to EMS data, not hospital data, unfortunately. It's statute 401.253, reporting of a controlled substance overdose. So, I mean, it's a step, and hopefully in the future, they become a reportable disease condition to the Florida Department of Health, just like a lot of other diseases are.
Yeah, I would imagine the legislature is a little reluctant to require a private organization or entity to do something, but even so, there are requirements, and we need to look into this to make your data that much more universal. Anyway, any other comments? from the task force? Any comments from the public? Our next meeting is June 14th. And thank you very much